Very good afternoon to everyone. Myself, Dr. Syeda from Sharavati Dental College and Hospital, Shivamogga. Before beginning my presentation, I would like to extend my sincere gratitudes and thanks to the organizing chairman, Dr. Arvind Moldi sir, organizing secretary, Dr. Basavkumar Majge sir, and to all the other organizing committee members for giving me an opportunity to present in this masterclass. I also like to extend my sincere thanks to our HOD, Dr. Srinidhi Bhatt, for supporting me to present in this masterclass. Today, the topic for my presentation is medical emergencies in dental office. And this is a most commonly asked question. But rather than having this as a question in the exam, it is a must for every dental professional to know how to manage the medical emergencies in the dental office. And I will be discussing this under the following headings. Introduction, classification of medical emergencies, guidelines to prevent the medical emergencies, action plan during medical emergency, common medical emergencies and prosthodontic considerations, medical emergency drugs and equipments, basic life support, conclusion and references. To begin with introduction, medical emergencies in the dental office are critical and unexpected events that compromise the health and integrity of the patients. They can happen to anyone, a patient, a doctor, staff member, or a person who is accompanying the patient. Prosthodontic procedures are often prolonged and sometimes stressful. They carry elevated risk for the medical emergencies as the elderly patients are treated. These situations can range from minor fainting or syncope to more serious conditions like allergic reactions or asthmatic attacks or cardiovascular accidents. What is a medical emergency? A medical emergency is a condition that demands immediate attention and good management to enable a successful outcome. These are the life-threatening situations that every practitioner needs to be aware of to help prevent the preventable injury, illness or death and to minimize the consequences of unavoidable emergencies. Classification of medical emergencies. According to Stanley Malamed, he classifies the medical emergencies as unconsciousness, respiratory distress, altered consciousness, seizures, drug-related emergencies, and chest pain. The second classification is based on cardiac orientation or cardiac involvement. It is subcategorized as stress-related non-cardiovascular, stress-related cardiovascular, non-stress related non-cardiovascular, non-stress related and cardiovascular. The second classification is physical status classification, which is developed by American Society of Anesthesiologists. This classification helps to assess the patient's overall health and risk level before performing any procedure. It is subdivided into 6 categories. In the category 1, a healthy patient with no systemic disease who carries a minimal risk during the treatment. Category 2, patient with a mild systemic disease with a slightly higher risk and may need some precautions. And in category 3, patient with the severe systemic diseases who carries a significant risk and need for medical consultations and modifications before performing any procedure. In the class 5, patient with the severe and advanced diseases with constant threat to the life. Only emergency treatment is carried out in a good multi-speciality hospital setup. Category 5 and 6 are brain dead patients. These emergencies 5 and 6 categories are very rarely to occur in the dental setup. Approaches to prevent the medical emergencies during the prosthodontic treatment. So, a thorough medical history of the systemic diseases like diabetes mellitus, asthmatic attacks, episodes of the epileptic attack, allergic reactions should be recorded as these conditions are more likely to cause the emergency situations during the dental treatment. Current and previous medications should be checked to prevent any drug interactions and complications. Physical examination. According to the McCarthy, proper physical examination can prevent 90% of the life-threatening situations. Remaining 10% are sudden and unexpected in spite of having all the preventive efforts or the measures. Basic physical examinations like checking the vitals like blood pressure, pulse, respiratory rate to identify any immediate risk. Determination of medical risk and anxiety level of the patient according to the physical status classification. Then stress reduction protocols for anxious patients. This could mean shorter appointments, good communication or sedation if needed. Pre-medications, prescribing the anxiolytics for the highly anxious patients or prophylactic medications should be considered for patients with the systemic diseases before performing any dental treatment. Then appointment scheduling and duration of treatment. This is very important in prosthodontic treatment. Schedule the appointment wisely. Treat the geriatric patient, especially with certain metabolic diseases and cardiovascular diseases, at the best time of the day for them, usually morning hours when they are less fatigued and stress levels are very less or low, and keep the duration of the treatment as short as possible. Adequate pre and post-operative pain control reduces the stress and prevent the further complications. Certain guidelines to be followed to prevent the medical emergencies. Recognize the type of medical emergency. It is very important first and foremost to recognize the type of medical emergency. Then training in the BLS. Dental team must be upskilled in the BLS techniques and should obtain certification at the level of BLS healthcare provider every year. Then training and practice in the use of emergency drugs and equipments. Then documenting and reviewing of the incidents. This review will help to identify the areas where more learning and training may be needed. Prosthodontic context to avoid the medical emergencies. Along with the medical history, a thorough history regarding the previous complications and with the dental treatment will help in preventing the future emergencies. Ask the patient about any previous allergic reactions with the local anesthetics, any dental materials like latex gloves, acrylic resin, zinc oxide eugenol impression paste and other impression materials, and with any other restorative materials like composites, dental cements and silver amalgam or any alloys. Action plan or the emergency management plan. When the emergency occurs, what to be done, how to manage. So here the BLS PCABD protocol should be followed. P is the position of the patient, C is the circulation, A is the airway, B is the breathing, D is the definitive care. Here when the emergency occurs, just look for the situation and have the safety of yourself and look for the safety of the patient. Then start with positioning the patient. Bring the patient to the proper position, that is supine or Trendelenburg position or recovery position, whatever with according to the type of emergency occurred. Then see for the circulation, check the pulse or the BP, then assess the airway clearance or open the airway, assess for breathing and then call for the help. Then determine the cause of the emergency and start with the definitive treatment or definitive care with the administration of oxygen, use of aromatic ammonia to stimulate the respiration, administration of emergency drugs with the CPR and use of artificial external defibrillator. Once the ambulance arrives, shift the patient to the emergency services. Then certain additional procedures like monitoring of vitals, loosening the tight cloths and clearing the area from the sharp objects which hinders the patient recovery should be done, and have the suction to clear the oral fluids. Then what is written action plan? Rule of golden period or golden 10 minutes should be followed to reduce the risk of death or illness or injury in every dental office by having a written action plan which is very well displayed in the dental office. A written action plan must be developed. This plan includes the plans for team training periodically, confirmation of who does what, information about the access to emergency services like emergency contact phone numbers and basic information required by the emergency services, instructions and direction to the office, easy access to the emergency drugs and equipments. This picture shows The preparation of dental office to manage or execute the plan of action in the case of medical emergency by posting the emergency assistant numbers and stocking of the available emergency drugs and equipments. And this should be the basic setup in every dental office, where you have clearly displayed the emergency contact numbers and the emergency services available, and you have to check for the expiry date of the emergency drugs and keep them ready to use whenever the emergency arises. Prosthodontic considerations during any medical emergency. Stop the treatment immediately. Remove any object or impression tray or the denture base or any removable prosthesis from the mouth, and even aerator handpieces, any implant prosthetic components, and drain the fluids by suction immediately to prevent the aspiration and choking, and adjust the chair to maintain the patient's position based on the type of medical emergency occurred. Now, certain common medical emergencies which occurs in the dental office, I would like to discuss under these following these headings: cardiovascular emergencies, cerebrovascular emergencies, cardiovascular emergencies, endocrinal emergencies, respiratory distress, emergencies with the local anesthesia, airway obstruction or choking, hemorrhage or bleeding, allergy to dental materials, temporomandibular joint emergencies. Cerebrovascular emergencies. Unconsciousness is associated with 50% of the medical emergencies. There are many precipitating factors for unconsciousness. Recognition of the cause of the unconsciousness is very crucial for emergency management. The main common symptom in the cerebrovascular accident is unconsciousness. The most common cerebrovascular emergencies we see in the dental office are vasovagal syncope, postural hypotension, stroke, seizure. Vasovagal syncope. Vasovagal syncope is the transient loss of consciousness due to cerebral hypoperfusion, characterized by sudden onset, short duration, and complete spontaneous recovery. The typical signs and symptoms include weakness, dizziness, pallor, sweating, hypotension, loss of consciousness. Predisposing factors are emotional stress, fear or the anxiety during the treatment. The management includes stop the dental treatment immediately, follow PCABD protocol of the basic life support, and then place the patient in the Trendelenburg position. As you see in this picture, the patient is positioned in the Trendelenburg position to improve the blood flow or blood supply to the brain. Then check for the airway, breathing, and circulation, monitor the vitals. Then respiratory stimulants like aromatic ammonia. As you see in this picture, the aromatic ammonia is a respiratory stimulant which is kept near the nostrils to stimulate the respiration or respiratory muscles. To overcome the hypoxia, oxygen at the rate of 6 to 8 liters per minute should be administered. Loose the tight clothing, assess the consciousness. Here in this, patient should be recovered by 2 to 3 minutes. If the patient is not recovered after 4 minutes also, then check for the vitals, and other causes of unconsciousness should be suspected. Next, we have the orthostatic or postural hypotension. This is the second most common cause of loss of consciousness. It is caused by sitting upright or supine for a long time, which leads to the drop in the blood pressure because of pooling of the blood in the periphery that is not remobilized quickly enough to prevent the cerebral ischemia when the patient changes his posture immediately or when the patient stands immediately. The patient will therefore feel lightheaded or become syncopal. Patient who remains conscious will usually complain of palpitations and generalized weakness. The management include terminate all the dental procedures, follow the BLS PCABD protocol and Trendelenburg position for the patient, monitor the vitals like blood pressure, pulse, respiratory rate. Once the blood pressure improves slowly, you have to monitor over a period of time, repeatedly check the blood pressure, and once the blood pressure improves, slowly return the patient to the sitting posture and discharge to home once the vital signs are normal and stable. Next we have stroke. Stroke is any vascular injury that reduces the cerebral blood flow to a specific region of the brain, causing the neurologic impairment. The signs and symptoms are based on the area of the brain damage. Main signs and symptoms to identify the stroke are the paresthesia in the contralateral part of the upper and the lower limbs, and the facial asymmetry and dysarthria. These are the classic symptoms of stroke. Then the clinical management includes recognizing the condition with looking at the paresthesia or asymmetry, facial asymmetry and dysarthria. Then applying the immediate BLS protocol, that is PCABD algorithm. Place the patient in Trendelenburg position, administer the oxygen. Continuous monitoring of vital signs is required and stabilize the patient till the arrival of the medical services. Then seizures. Seizures are sudden uncontrolled electrical disturbances in the brain that can cause a variety of symptoms including convulsions, loss of consciousness, muscle stiffening or unusual sensations. Grand mal seizures are generally seen in the elderly patients, and they are usually generalized type of seizures which are characterized by tonic-clonic phase. In the tonic phase, the body becomes rigid, accompanied by loss of consciousness and loss of balance and sometimes vocalization. The subsequent clonic phase involves rhythmic jerking movements that can last up to 2 minutes with possible mouth rigidity, frothy saliva and associates with the urination. If the seizures last longer than 5 minutes, or if there is repeated seizure activity without full recovery, this may indicate status epilepticus, a condition called status epilepticus, which is a medical emergency requiring immediate attention. The management. Effective management of epilepsy focuses on injury prevention. Clear the area of sharp objects and create a safe space by using the cushions or blankets, especially for the patient's head. Here the patient will be having continuous convulsions and more chances of the patients having the injuries. So protecting the patient is first priority in the case of epileptic attack. It is crucial not to restrain or stop the patients or insert any objects between their teeth. Administer supplemental oxygen at the rate of 15 liters per minute and have suction equipments ready to clear the fluid from the oral cavity after the seizures have concluded. Check blood glucose levels to rule out hypoglycemia, particularly if the patient has no history of seizures. And if it is confirmed that it is a status epilepticus, then emergency protocol should be activated. Anticonvulsants should be administered intravenously, that is lorazepam 0.1 mg per kg or 2 mg per minute should be administered intravenously, and that should be done with the emergency medical personnel only. Prosthodontic considerations for epileptic patients. Medical history regarding the epilepsy and previous attacks should be taken. Evaluating the medications for epilepsy. Specific treatment planning like avoiding removable prosthesis due to the danger of aspiration or swallowing during attacks. Treatment should be carried out by placing the removable appliances in the mouth, by ligating it with the floss, or by placing the oral screen or the packing or gauze. Treatment should be done in the calm and stress-free environment. Syncope in the pregnant patients or supine hypotensive syndrome. The gravid uterus may obstruct or diminish the blood flow through the inferior vena cava on the right side of the abdomen, tapping large amount of the blood in the legs. Here, the management includes turn the patient to the right side, tuck a pillow or blanket under the left side of the patient's back to help her maintain in that position. and carry out only emergency treatment for the pregnant woman. Limit the treatment with the short appointments with the appropriate positioning. Here the positioning of the pregnant woman is very critical as mentioned earlier. So it leads to the hypotension due to the compression of the inferior vena cava. So do not give any medications during pregnancy. Give strict oral hygiene instructions. Next is cardiovascular emergencies. Another potential emergency we see in the dental office is the chest pain. Most of the time, chest pain leads to many cardiovascular accidents like angina pectoris, acute myocardial infarction, and other cardiac arrest. So the chest pain may be like squeezing, tightness, fullness, constriction, pressure, or heavy weight on the chest. Usually, if the patient is experiencing angina pectoris or myocardial infarction, patient will be conscious. If the patient becomes unconscious, then cardiac arrest is suspected. Prosthodontic considerations for the patients with the cardiovascular diseases. A thorough medical history in every case. Evaluation of the medications, like patients may be on anticoagulants or beta blockers or any other medications. So before doing any surgical procedures or any extensive dental procedure, so a cardiologist opinion should be taken on medications which the patient is taking, and consideration of pre-medication, that is for any surgeries. So the pre-medication is prescribed by taking the cardiologist opinion. Then local anesthetics should be given with the minimum vasoconstrictor concentration. Then scheduling the appointment again for such patients is usually at the morning, and again short appointments are preferred. Then angina pectoris. Here it presents as mild or the lower retrosternal pain with a sudden and oppressive onset, typically radiating to the left arm or the jaw, sweating, elevated heart rate and BP, and feeling of faint, and the patient may become unconscious. The management include halting all the dental procedures, and once again carrying out the BLS PCABD protocol, and check the BP of the patient. If there is no hypotension, then administer 0.6 milligram of sublingual nitroglycerin. If the symptoms persist, nitroglycerin can be repeated every 5 minutes up to 3 doses. Then oxygen supplementation should be continued till the oxygen saturation exceeds 90%, and emergency protocol should be activated. If there is no improvement, acute myocardial infarction is suspected, and transferring the patient to the emergency hospital care immediately. Acute myocardial infarction. This presents with the intense and prolonged retrosternal pain with shortness of breath, decreased blood pressure, nausea and vomiting. Persistent and worsening pain along with the irregular pulse suggests the MI. Here the difference between the anginal pain and the acute myocardial infarction is, in the anginal pain there will be an increase in the blood pressure, and in the myocardial infarction the blood pressure goes on decreasing, and the pain will be continuous pain which is worsening. So these are the main differences how to identify. Then the management of myocardial infarction include positioning the patient in semi-upright position. The very important thing in myocardial infarction is we have to administer the aspirin here, but whereas in the anginal pain we are administering the sublingual nitroglycerin. So in the management of the myocardial infarction, positioning the patient in the semi-upright position, here you can see in this picture, the patient has placed in the semi-upright position, and oxygenating the patient, and administration of 150 to 300 milligram of aspirin as the initial treatment. Then alternatively 0.6 milligram of nitroglycerin may be administered sublingually, and transfer the patient immediately to the hospital care, and once the vital signs are stable. Then cardiac arrest. Sudden collapse, sudden unconsciousness, no pulse, sudden drop in the blood pressure indicates the cardiac arrest. To identify the cardiac arrest, look for the signs such as unresponsiveness, unconsciousness, and absence of the normal breathing or gasping. Management include halt the dental procedures immediately and initiate the BLS PCABD protocol, positioning the patient Then activating the emergency protocol here in case of cardiac arrest, along with the CPR, cardiopulmonary resuscitation, use of automated external defibrillator is advised till the arrival of the ambulance. Then shock or the cardiogenic shock. Cardiogenic shock is the circulatory inefficiency that creates an imbalance between the tissue oxygen supply and oxygen demand. Cardiogenic shock is due to the failure of the heart to pump effectively. Extreme anxiety and stress can induce cardiogenic shock as a medical emergency. The management includes, or before management, I would like to tell about the clinical signs and symptoms. The signs and clinical manifestations are hypotension, tachycardia, weak thready pulse, sweating, cool, pale and moist skin, shortness of the breath, confusion and loss of consciousness. The management is once again PCABD protocol, activating the emergency protocol and use of use of automated external defibrillator along with the cardiopulmonary resuscitation. Next is hypertensive crisis. Hypertensive crisis is an acute elevation of the blood pressure requiring urgent medical attention with the diastolic values above 120 mm of mercury and systolic values above the 210 mm of mercury. To assess, it is essential to identify the underlying causes and evaluate the damage to the target organ. Predisposing factors include anxiety and stress, fear of dental treatment, even the aortor handpiece noise can precipitate the hypertensive crisis. Then improper or the skipped medication habits including smoking and the diet with the more salt and spices. The clinical manifestations include sudden and severe headache, dizziness, shortness of breath, blurred vision, chest pain, confusion and weakness. The management of hypertensive crisis include confirming the blood pressure readings with a properly functioning sphygmomanometer. Place the patient should be placed at the rest, lying down and emotionally calmed. Blood pressure should be reassessed after 15 to 30 minutes again. If the elevated blood pressure persists, activate the medical assistance, initiate the pharmacological treatment with administration of calcium channel blockers or angiotensin converting enzyme inhibitors. Then endocrinal emergencies. In the endocrinal emergencies, first I would like to discuss about the hypoglycemia. Patients with the clinically significant hypoglycemia may be recognizable because they commonly experience diaphoresis, that is excessive sweating, shakiness, tachycardia, confusion, dizziness and loss of consciousness. The management include the treatment protocol include stop the dental treatment immediately, put the patient in the recovery position, not in the Trendelenburg position, put the patient in the recovery position, follow the BLS PCABD protocol, and then if the patient is conscious, then administer 10 to 20 grams of glucose. If the patient is unconscious with the hypoglycemia, then parenteral administration of glucose is required. Administration of the oxygen at the rate of 15 liters per minute and prepare to inject glucagon intramuscularly. Immediately call for the assistance. Malamutes recommends that the dentist should never place any drug or any other object in the mouth of an unconscious patient. Then hyperglycemic crisis, a potentially fatal condition that can lead to the loss of consciousness associated with the diabetic ketoacidosis or hyperglycemic hyperosmolar state in the patients with type 1 and type 2 diabetes mellitus. Predisposing factors include inadequate insulin therapy, infections, stress, certain medical conditions and medical emergencies like stroke and heart attack leads to the hyperglycemic crisis. The clinical manifestations include, along with the diabetic ketoacidosis, which is acute in nature, there will be nausea, vomiting, abdominal pain, tachypnea, hyperventilation, acetone breath and diabetic ketoacidosis are the classic symptoms of the hypertensive crisis. And then there will be an alternate perception. The management of hyperglycemic crisis include monitoring the vital signs and providing the BLS protocols, that is PCABD protocol. In the case of loss of consciousness, following the PCABD with the CPR and the by BLS protocol should be followed here. Then administering the intravenous solution if possible, and awaiting the medical help. Here the administration of intravenous saline is mainly indicated here in the hypertensive crisis. Prosthodontic considerations for the diabetic patient. Take proper medical history and check the medications. Inquire about the patient's diet and check the blood glucose level before beginning any dental procedure. Schedule the appointment preferably in the morning and keep the short appointments. Follow the modifications in the treatment protocol for the diabetic patients. Then is the adrenal insufficiency. Adrenal insufficiency is a true medical emergency in which the victim is in immediate danger because of the glucocorticosteroids deficit. Primary adrenal insufficiency is the Addison's disease. Secondary adrenal insufficiency is due to adrenal insufficiency secondary to the exogenous corticosteroid administration. This secondary adrenal insufficiency is more common to see in the dental offices, and it is precipitated easily due to the predisposing factors. The precipitating factors include physiologic stress due to the traumatic injuries, surgeries including the maxillofacial surgeries, periodontal surgeries and endodontic surgeries, extensive dental procedures, acute changes in the environmental temperature, severe muscular exercise and burns, and psychological stress such as the stress seen in the fearful patient and may also precipitate the adrenal crisis. The clinical manifestations include mental confusion, nausea, vomiting, fatigue, muscle weakness, pain in the abdomen and lower back and legs, vomiting and hypotension and loss of consciousness. Management of adrenal insufficiency. There are different ways to manage the adrenal insufficiency. If the patient is conscious and asymptomatic, make the patient sit comfortably and then see for the airway, breathing and circulation. And if the patient is symptomatic, then place the patient in the semi-supine position, then start to administer the glucocorticosteroids. And if the patient is totally unconscious, start with the PCABD protocol and call for the medical assistance, obtain the emergency kit and administration of oxygen, monitor the vital signs and administration of the glucocorticosteroids in presence of medical personnel. So these are the two methods how you manage the adrenal insufficiency. Now, respiratory distress. First is anaphylaxis. Anaphylaxis is a potentially fatal, acute, life-threatening systemic hypersensitivity reactions with a wide range of clinical manifestations, and they may cause death within the few minutes. A delay in the recognition of the initial signs and symptoms of the anaphylaxis can result in airway obstruction or vascular collapse. It is a type 1 hypersensitivity reaction with localized or systemic allergy due to exposure to certain allergens. Especially in the dental office, the allergens include local anesthesia with the ester type are more to cause the allergic reactions, and even the latex gloves, they causes the perioral edema or other severe itching of the skin, and the certain methyl methacrylates also causes the severe allergic reactions. Signs and symptoms of the anaphylaxis include the cutaneous signs and symptoms. Cutaneous or skin reactions are seen as urticaria, erythema, periorbital and perioral edema. Respiratory symptoms include cough, stridor, dyspnea, laryngeal edema and bronchospasm. Smooth muscle symptoms include abdominal pain, nausea, vomiting and diarrhea. Cardiovascular symptoms are syncope from the hypotension, tachycardia, arrhythmia and shock. The management of anaphylaxis shock include start immediately with the PCABD protocol and administer 15 liter of oxygen per minute. If you have taken a case history of the patient who is allergic, then you administer the antihistamines like diphenhydramine 50 to 100 milligram intravenously or intramuscularly, and vital signs should be monitored. If the reaction progresses to severe anaphylaxis or anaphylactic reaction or anaphylactic shock, emergency services should be contacted. Administration of 100% oxygen and injection of epinephrine is considered. Epinephrine 1:1000, that is 1 milligram per ml ampule subcutaneously should be administered immediately till the emergency services arrives. Next we have asthma. The most common cause of respiratory distress seen in the dental patients is asthma or bronchospasm. It may present with the acute symptoms such as wheezing, accessory muscle use during breathing, tachycardia, tachypnea, bradycardia, confusion, and decreased consciousness. Stress and anxiety and some medications and allergies can induce the asthmatic attack. A severe form of the asthmatic attack, which is called as status asthmaticus. Here there will be continuous episodes of breathlessness without gap. The management of asthmatic attack include halt the treatment immediately and follow the BLS PCABD protocol. Put the patient in the supine position. Oxygen until the oxygen saturation, administration of oxygen until the oxygen saturation exceeds 90%. Then the inhalation, via inhalation, salbutamol 100 mcg should be given. It should be repeated up to 3 times. If there is no improvement with the inhaled corticosteroids, emergency protocol should be activated and adrenaline with 1:1000, that is 1 milligram per ml should be administered intramuscularly or subcutaneously for the adults. It is very important to consider the asthmatic history before giving prophylactic medications for any extensive dental procedure, as in the patients with asthma, aspirin and other non-steroidal anti-inflammatory drugs and penicillins are contraindicated as they might trigger the asthmatic attack. Next we have the hyperventilation. Hyperventilation is defined as the ventilation in excess of that required to maintain the normal blood arterial oxygen tension and arterial carbon dioxide tension. Hyperventilation is a common emergency in the dental office. Almost always it is a result of extreme anxiety. Here what happens? Excess of carbon dioxide is removed from the lungs. The clinical manifestations include altered hyperventilation or more commonly produces altered level of consciousness. Victims report feeling of faint, lightheaded mainly due to alkalosis. As I told earlier, there will be an excess removal of carbon dioxide from the blood. So there will be alkalosis which has occurred. This leads to the feeling of lightheadedness. Then numbness or tingling sensation in the extremities and around the mouth, lips, muscle twitches, difficulty in catching up a deep breath are the major symptoms. The management of hyperventilation include terminating the dental procedure, positioning the patient in semi-erect position or the semi-supine position. If the symptoms of the alkalosis occur, the patient should be forced to breathe into a cover or the small bag where inhalation and exhalation in the same bag leads to the more concentration of carbon dioxide. Then oxygen rich air is not indicated. If the hyperventilation continues, the clinician may have to activate the immediate medical assistance and administer a sedative such as midazolam by giving 2 to 4 milligram intramuscularly. Then let us see what are the local anesthesia complications. The complications with the local anesthesia are mainly systemic complications and local complications. The systemic complications include drug-related allergy. It is usually, once again, due to the ester type of local anesthetics, they causes the allergic reactions leading to the anaphylaxis. So the management of anaphylaxis is already discussed and it should be managed accordingly. Then overdose reactions. Overdose reactions are seen in the central nervous system. The always take central nervous system and cardiovascular systems. Always take the weight of the patient into account for deciding the dose of the local anesthesia. Signs and symptoms of the overdose reactions are seen in the central nervous system and cardiovascular system as excitation, convulsions, loss of consciousness, hypertension, tachycardia and arrhythmias. Now, how much of local anesthetic can be injected safely without any complication? The maximum LA which can be injected is without adrenaline 300 milligram or 4.4 milligram per kg. With adrenaline 500 milligram or 7 milligram per kg can be injected. So, if you calculate this into ml, 25 ml, that is LA with adrenaline, 25 ml can be safely given in a healthy individual without any complications. The next complication with the local anesthesia is methemoglobinemia. This is a condition where iron in the hemoglobin is stabilized into ferric, that is F3, where the hemoglobin becomes unable to bind with the oxygen. Local anesthesia, especially the prilocaine and benzocaine, if injected in the higher doses, increases the risk of methemoglobinemia. The signs and symptoms include the cyanosis, mainly the cyanosis in the mucous membrane, hypoxic symptoms, headache, dizziness, fatigue, dyspnea and tachycardia. Then the management of methemoglobinemia include supplementation of 100% oxygen immediately, monitor the vital signs, call for the medical assistance, then IV administration of methylene blue, which is a heterocyclic aromatic compound which increases the rate of conversion of methemoglobin to hemoglobin. Then the local complications. The local complications are usually related to the improper techniques or faulty techniques of the administration of local anesthesia. In that, mainly we have the needle breakage, usually associated with the inferior alveolar nerve block. When the needle is broken, if the needle is visible, then immediately remove it with the hemostat. If it is not visible, shift the patient immediately to the hospital, take a CT scan to locate the needle, and patient should be operated based on its location. Then nerve damage during injection. Needle may damage the intraneural blood supply, resulting in the hematoma. Hemorrhage around the neural sheath also causes pressure on the nerve, leading to the swelling and paresthesia, usually associated with the posterior superior alveolar nerve block. The treatment of the hematoma include pressure, cold packs, analgesics are advised for treating hematoma. Then trismus. Needle may traumatize the medial pterygoid muscle which results in the trismus, and also the multiple injection in a short period in the same area of the muscle during inferior alveolar nerve block leads to the trismus. The management includes advice for the muscle relaxants, physiotherapy, heat therapy and soft diet. Then facial nerve paralysis, which is caused by induction of the local anesthetic into the capsule of the parotid gland. During inferior alveolar nerve block, if the needle is inserted too deeply and too far dorsally, the terminal branches of the facial nerve within the deep lobe of the parotid gland are affected, leading to the unilateral facial paralysis. So, it may disappear over a period of time. These are some of the pictures showing the complications of posterior superior alveolar nerve block, that is hematoma due to the damage to the neural sheath. And here, as the needle is inserted far dorsally and posteriorly, this hematoma results. And in the second picture is the picture showing the unilateral facial paralysis as a complication of inferior alveolar nerve block. Then management of complication of local anesthesia. activation of emergency protocols and BLS PCABD algorithm. Oxygen therapy should be started until the oxygen saturation exceeds 90%, and constant monitoring of the patient is required. In presence of emergency personnel, administer diazepam 10 mg intravenously to control the seizures. Then prosthodontic considerations in prevention of complications with local anesthesia. A history should be asked about the reactions with the LA, concern during the implant surgery and any other FPD treatment. Always check the BP and blood sugar before giving the local anesthesia. Use aspiration to avoid the intravascular injection. Then use of amide type of local anesthetics to prevent any allergic reactions. Keep the dose minimum but sufficient for the pain control, and follow the proper correct technique of injecting the local anesthesia. 2% lidocaine with 1:2 lakh adrenaline is advised in the hypertensive patient. If the patient's BP is severely uncontrolled, use the plain local anesthetics without adrenaline. Next we have airway obstruction or choking. During the dental treatment, there is a great potential for the small objects to drop into the posterior portion of the oral cavity and subsequently into the pharynx, causing the airway obstruction. According to the Melamed statement, the dental instruments recovered after choking and aspiration are head of the aerator handpiece, burr, mouth mirror heads, implant, prosthetic components like multi-unit abutment screws, screwdrivers, endodontic instruments, crowns, rubber dam clamps, post and cores. These are the radiographs showing aspiration of rubber prophylaxis cup and gold crowns. You can see the dislodged crowns and rubber cup due to the aspiration. Here, this picture shows the implant hex and the multi-unit abutment and the screws with the smallest dimension. Here it is compared with a small tablet Dexona. You can see white round thing, that is the Dexona tablet, which is the smallest tablet of about 4 to 5 millimeter, and it is compared with the dimension of the multi-unit abutment screws and other prosthetic screws which are of the same dimensions. So these smallest objects have the high chances during the treatment to be swallowed or aspirated. So extreme care should be taken while using these prosthetic components during implant treatment procedures. Next, the clinical manifestations of swallowing or aspiration. Signs and symptoms exhibited by the patient help determine if the patient has entered, if the object has entered into the trachea or it is swallowed. First, we should confirm whether the object is swallowed or it is aspirated into the lungs. There will be a different signs and symptoms through which we can locate. If the object has entered into the trachea, then there will be sudden onset of coughing, choking, wheezing and shortness of breath. This will lead to the complete airway obstruction or partial airway obstruction. In the complete airway obstruction, there will be inability to breathe, cough and choking, and patient will become panic. In the partial airway obstruction, there will be forceful coughing, wheezing, altered voice sounds and cyanosis and disorientation. The prevention of aspiration or swallowing of the objects. Mainly we have to use the rubber dam, oral packing 4x4 inch gauze or oral screen, then suction, ligature with the dental floss, then Magil intubation, forceps. Here, this picture showing how to prevent the aspiration of prosthetic components during implant procedure. Here usually the screwdrivers and other screws are ligated with the dental floss to prevent the aspiration during treatment. The management of swallowed objects. There are various methods to manage the swallowed objects. If a dental assistant is present during the treatment, if the object is swallowed and it is visible, then place the patient into the supine or Trendelenburg position and use a Magill intubation forceps or the suction to remove the foreign body. If it is not present, instruct the patient, and if it is not visible, then consult the radiologist immediately and obtain the appropriate radiograph to determine the location of the object and initiate the medical treatment immediately. If the object is visible, then ask the patient to forcefully cough. Ask the patient to bend down and cough. If it is visible, you can remove it even with the Magill forceps. Then, if the object is aspirated, then place the patient in the left lateral decubitus position. And after placing the patient in the left lateral position, encourage the patient to cough. If the foreign body is retrieved, initiate medical consultation before discharge. If the foreign body is not retrieved, then consult the radiologist or emergency department, obtain the appropriate radiographs to determine the location of the foreign body, perform bronchoscopy to visualize and retrieve the foreign body. So along with all these procedures, the basic life support including the airway maintenance is initiated immediately till the arrival of the medical team. The basic airway maneuvers are performed here. That is back blows or the back slap, chest thrust or the abdominal thrust or the Heimlich maneuver should be performed. In the back blows or the back slap, as you see in this picture, support the patient's chest with one hand and lean them forward. This may dislodge the foreign body. If the symptoms continue, deliver up to 5 back blows or the back slaps between the scapulae using the heel of the hand. After each blow, check whether the foreign object is dislodged or not. Then you have abdominal thrust or the Heimlich maneuver. Make the fist with one hand. Place the thumb side of the fist against the victim's abdomen. Hand should rest in the midline slightly above the umbilicus and well below the tip of the xiphoid process. Grab your fist with your other hand and press your fist into the victim's abdomen with quick, forceful and upward thrust as you see in this picture. Even after this, the airway obstructions are not cleared off from the foreign objects, then shift the patient immediately to the hospital or emergency services to surgically open the airway and remove the foreign objects with the tracheostomy or corticotomy. Then you have hemorrhage or bleeding. Bleeding is another scary medical emergency in the dental office. The predisposing factors include hypertension, hemophilia, von Willebrand syndrome, patients on anticoagulants and surgical complications. When bleeding becomes an emergency in the dental office. Due to the complications during the extensive maxillofacial and implant surgeries, traumatic extractions and accidental damage to the arteries and veins during performing the dental procedures. Example is damage to the deep lingual artery and vein with the erotor handpiece during crown preparation when the patient suddenly moves. So these are the emergencies when you can see the excess bleeding intraorally. Then management of the bleeding in the dental office. Here apply the digital pressure, application of chemical hemostatic agents like trexanamic acid, that is antifibrinolytic, ferrous sulfate, silver nitrate, then hemostatic gauze, oxidized regenerated cellulose, collagen sponge, resorbable gelatin sponge and suturing the bleeding site if required. Then management of accidental trauma to the deep lingual artery or vein. Here immediate pressure is applied, then repositioning of the patient to upright position to prevent blood pooling in the back of the throat. Then assess and manage the airway. Administration of local anesthesia with 1:80,000 adrenaline and then surgical ligature is initiated here. Call immediately the medical emergency services and take the patient to the hospital. Here the surgical ligation should be initiated, or embolization should be done. Interventional radiologist will perform angiographic embolization to block the artery. This is the way how you manage the accidental damage to the deep lingual artery. Then allergies to dental materials. The dental materials exhibit usually delayed or type 4 type of allergic reactions in patients, dentist and lab personnel. Type 4 allergic reactions are reported in literature with the different dental materials like latex gloves, nickel chromium alloy, impression materials, endodontic materials, formaldehyde, sodium hypochlorite, etc. Even titanium has caused the allergic reactions which is reported in the literature. But immediate allergic reactions also occurs with the dental materials. They are very few, but if they occur, it will be an anaphylactic reaction. This is mainly due to the ester type of local anesthetics and its components like sodium metabisulfate. These are the main dental substances, that is local anesthesia, which causes the anaphylactic reactions or immediate reactions. Even the latex gloves in some patients also initiate the allergic reactions like perioral edema and itching and urticaria in some patients. Prosthodontic considerations to avoid the allergic reactions. Here, if the patient gives any history of allergy, then go for MELISA or the patch test if the patient gives any history. Then use of nitrile gloves, then use of amide type of local anesthetics, which usually do not causes allergic reactions. The allergic reactions are seen with the ester type of local anesthetics. Then nickel-free alloys and complete elimination of the residual monomer before denture delivery and use of the metal denture base and eugenol-free zinc oxide eugenol impression paste with tricarboxylic acid, which replaces the eugenol in patients with allergy. Next is emergencies with the temporomandibular joint. The main few emergencies which occurs with the temporomandibular joint are disc displacement without reduction, leading to the jaw locking or deviation after prolonged dental procedures. The management includes manual palpitation of the mandible to unblock the articular disc. Next is the sudden and acute contraction of the inferior lateral pterygoid muscle leading to the limited mouth opening. The management includes move the lower jaw back under the pressure of the fingers placed in the area of the chin. Next we have subluxation and luxation of TMJ. These are very commonly we see in the dental practice. When the patient is unable to close the mouth from maximal opening after a longer dental procedure, this means that head of the condyle of the mandible is in the front of the articular tubercle. This could be either subluxation or luxation. Now, how will you identify whether it is subluxation or luxation? Subluxation is diagnosed when the patient is able to close his mouth on his own. But whereas in the luxation, it is diagnosed when the patient needs someone helps to return to the condyle, to the proper position in the joint. Myofascial pain dysfunction syndrome. There will be a sudden onset of pain in the masticatory muscle, head and neck area on the one side of the body, excessive tension and frequent contraction of the muscles associated with the stress, anxiety and frequent parafunctional activity. This condition requires specific treatment and it should be followed up properly. And this MPDS will arrive anytime. It will trigger anytime during the dental treatment. Then other emergencies with the temporomandibular joint which leads to the reduced mouth opening leading to the difficulty in dental treatment are hypertrophy of the coronoid process of the mandible and attacks of the fibromyalgia. Emergency drugs. The entire dental team should be familiar with the dosage and route of administration of all the emergency drug. It is not just you keep all the emergency drug in the dental office, but it is equally important you should know how to administer it. Not only doctor, all the staff members should be very well aware of dosage and route of administration of all emergency drugs. Usually, use of intravenous drug is discouraged for the practitioners who do not regularly administer the drugs through the intravenous route. Intramuscular, sublingual, buccal or intranasal will be quicker and easier in an emergency situation. So the following are the important drugs which should be kept ready in the dental office whenever there is to manage the medical emergency. That is adrenaline injection 1:1000, 1 milligram per ml, aspirin dispersible tablet, glucagon injection, glyceryl trinitrate, midazolam 10 milligram, oral glucose solution, tablet, gel or powder, oxygen, then salbutamol aerosol inhaler, flumazenil. If this is kept used only in the case if the treatments are carried out under the sedation with the benzodiazepines. Next are the medical emergency equipments. Every dental setup should have the following basic emergency equipments. In that, automated external defibrillator and adhesive pads, large volume spacer device for inhaled bronchodilators, oropharyngeal airways, oxygen cylinder, oxygen mask with the reservoir bag, portable suction or small mechanical suction, self-inflating bag with the reservoir and appropriate face mask. So this is the trolley where you can arrange the emergency drugs and equipments, and there should be a, as I said earlier, written action plan should be displayed and all the staff members should be aware of emergency drugs and equipments to use in the during the appropriate time. So now the last topic, that is the basic life support. Basic life support is a specific level of pre-hospital medical care provided by trained responders in the absence of advanced medical care. Every medical professional should be trained in performing basic life support. This includes, once again, as I have already mentioned, follows the PCABD algorithm. Here, whenever there is emergency arises, what you should do? That is your action plan, which is I have already discussed in brief in the earlier. So, check for the hazard or emergency and ensure safety of yourself and victim. You can see step by step in this diagram here. First is the, when you see the danger, you see the safety of yourself and the victim, and then you proceed. Then in the second step, you see check for the responsiveness of the patient victim. If the unresponsive, then call for the ambulance. You can see step by step. If the patient is unconscious, then immediately call for the ambulance services. Then PCABD protocol, that is maintain the position of the patient, check for the circulation, airway, breathing, and perform cardiopulmonary resuscitation if required. Then start using automated external defibrillator. So this is the basic protocol of the basic life support when you see an emergency. So after this, I would like to briefly discuss about the cardiopulmonary resuscitation. It is a technique of basic life support for oxygenating the brain and heart until appropriate definitive medical treatment can restore normal heart rate and ventilatory action. Very important things to remember is brain may sustain damage after the blood flow has stopped for 4 minutes, only 4 minutes, and irreversible damage will occur after 7 minutes. So brain dead will be there after 7 minutes. So whatever you have to do, it should be done within the 7 minutes. That's why I mentioned earlier, golden period or the golden 10 minutes should be remembered to achieve success in your basic life support or CPR. So then CPR is effective only if it is performed within 7 minutes of stoppage of the blood flow. Effective CPR enables enough oxygen to brain to delay the brainstem death and allows the heart to remain responsive to defibrillation efforts. The indications of CPR include severe injury and bleeding, asphyxia, heart failure, allergic reactions, electric shock and drowning. Now let's see briefly how to perform cardiopulmonary resuscitation. You can see two pictures here. In the first picture, it is CAB protocol. What is the CAB protocol? Here it is, first C is the compression. You have to start doing compressions in the CPR. Then you have to C for airway. That is compressions. First you have to start, that is 30 compressions at the rate of 3 compressions for every 2 seconds should be given. Then check for the airway. Open the airway by lifting the head up. Then after opening the airway, then you have to give mouth to mouth breathing. That is breathing, close the nostrils and cover the mouth with one hand and give 2 breaths. That is blow steadily 2 seconds into the victim's mouth. Watch for the chest rise. And then you have to repeat this 5 cycles. See, whatever I told, compression, airway opening, mouth to mouth breathing. You have to repeat this for 5 cycles till the arrival of the emergency services. So this is how you have to do the CPR. So to conclude, medical emergencies can occur in the dental office and it is important for entire dental team to manage every emergency. For the successful management of any emergency, all the staffs including the dentist have to get trained periodically with certified courses of BLS and keep themselves updated. Every dental setup should be equipped with basic required emergency drugs and the emergency equipments for accurate and on-time execution of plan of action during medical emergencies in the dental office. So these are my references. Thank you very much for your patience listening. If you have any questions, you can ask. Once again, I thank the organizing committee members for giving me this opportunity to present in this masterclass. I thank everyone for the patient listening. Thank you very much once again.